Welcome back. Dr. Cohn has a brief message for you guys, and then we're going to get started with the next section moderated by Dr. Levine.
One thing I wanted to make sure, a question that came up during the break, I wanted to make sure everybody is aware of the fact that all of the discovery resources that I talked about this morning are accessible to all. You don't need to be at the University of Michigan. We work with other universities, academic investigators. We actually have a lot of industry partners as well who come in and use various resources like the cryo-EM facility, et cetera. So please contact me or go on the Michigan Drug Discovery website if you have an interest in any of the resources I described today. Thank you.
I'm going to give people just a minute to get back to their seats, and I reached into my pocket and I pulled something out that is part of, I don't know if people are familiar with the very trendy construct of a daily carry for men, which are things that people carry all the time with them. So this is part of my daily carry. This is a touchstone that was distributed at Mary's Memorial, many years ago. So I carry her in my pocket. I can touch her whenever appropriate and necessary. And this is a moment because this is all about our trying to keep a promise that I made to her that I would do all that I could to help find cures and new preventive strategies for diabetic retinal disease, so other generations wouldn't have to suffer as she did from vision loss. So I apologize for that little digression. I guess we have most people back in their seats, so that was worthwhile. So I have my clicker. So we're going to talk a little bit about use of real world data, and of course what everyone's interested in is artificial intelligence approaches to diabetic retinal disease. I just want to frame use that as a lens to frame what we've already talked about. Of course, we've said that we've mapped a path to a cure, and a substantial part of that has to do with collecting data, whether it's as an outcome of our staging update and trying to accumulate the data that will allow us to do a better job in staging and assessing severity of diabetic retinal disease, or whether it's in the novel endpoints identification project, which Jenny talked so well about, and of course in terms of the biorepository and the omic data that we're going to be collecting. But if we put a lens of AI on that and integration of real world data, then as Jenny described in detail, our DRD staging update, the whole point is to create a multidimensional DRD staging system that can diagnose diabetic retinal disease earlier, better quantify, because all of the assessments, including our functional assessments that we're looking at, are quantitative assessments. So we want to better quantify DRD severity and risk of progression, including in the earlier stage diseases everyone has talked about. Critical is, of course, incorporating patient perspective and measures of function and physiology and molecular, immune, and systemic factors. So we start to imagine the weight of all the data that it has to be assembled in order to get to this new staging system that can be reduced to a score that can be acted upon by clinicians or used for patient selection in clinical trials. So it's as we do all this work, as we collect all this data, how do we then learn from it in a fashion that gives us a new way of approaching understanding the disease and disease state and risk of progression, but also how do we also use generative tools so that it's a continuously learning device so that we can, using real world data to update continuously. So part of what our next phases we'll look at, and we'll talk about this in next steps. And is about, we talked about this in May, creating a data lake, so into which we can start to capture the data from our staging update, the data from our clinical studies, the data from our collaborators, and including imaging data, which we'll be able to at least start by accessing millions of images in the Joslin database, but we want to be able to add additional imagery, to that. Of course, incorporating the structural and functional variables that we identify in our clinical trials. Those are, quote, small. They're well powered, but they're still small. So the question is, rather than in sequence, we can in parallel persuade our collaborators to start to use those those identified functional variables that have been identified through an expert process in their studies. And I'm happy to reinforce what Aud said earlier about Evired now looking at as a kind of an addition to their work, starting to look at some of these functional variables on their data set. And of course, as we've talked about, the importance, you can't really use real world data and you can't really incorporate all the clinical study data, well, unless you're actually mapped to common data models. So that's part of our, our process, going forward, is to be a motivator for this, as well as to, act as we are asking others to act and do take this approach in everything that we're doing. And of course, in everything that we do, we want to be able to integrate tools for harmonization analysis. Another one of our purposes, of course, is to encourage and facilitate data sharing. We've done, we've created that position for ourselves as being a critical part of accelerating progress. Of course, our May workshop in Seattle, we've already published a summary of those findings, which you all in TVST, which you all can find. And then, of course, it's engaging the broader community. Dr. Abramoff, talked about CCOI, which importantly has been renamed the Collaborative Community on Ophthalmic Innovation. And we hope to bring our learnings from our staging update and from our clinical studies into that environment and start to, as Dr. Eidelman, talked about, building consensus within the community about what are the endpoints that we can use for new therapeutics development and to guide improved clinical care and outcomes. We're already 15 minutes late. Sorry, but we've obviously had a really good first couple of sessions, and I'm glad we took the time to engage the panel and the audience. We're going to proceed now with perspectives from two exceptional scientists. First up is going to be Tian'en Tan, who is going to talk about multimodal AI for enhanced diagnosis, risk stratification, and prognostication. One thing that I'll mention about Tian'en is that he was a co-lead of our vascular retina work group and helped write that paper, and of course it's been working on AI for diabetic macular edema for some time. I'm not sure that everyone in the room knows, but along with Research to Prevent Blindness, the Mary Tyler Moore Vision Initiative does a competitive award of a Physician Scientist Award every year. This year is our second, last year was our first, and we're really happy to be able to bring Brian Vanderbeek to up to speak to the group. He's the recipient of the first Research to Prevent Blindness Mary Tyler Moore Vision Initiative Physician Scientist Award. He's an epidemiologist, University of Pennsylvania, who has a specific interest in using real-world data to assess, and his particular project is to evaluate what we now know about prevalence and incidence of diabetic retinal disease. So Brian, I really appreciate the fact you're here, and that will give us an insight as to how do you use real-world data in order to learn more about what's going on.
Well, thank you for the kind introduction. First, I'd like to thank my co-authors, Yin-Chi Yu, Rebecca Hubbard, and Serena Cardillo. But mostly, I can't tell you how honored I am to be the inaugural Research to Prevent Blindness Mary Tyler Moore Vision Initiative Physician Scientist. Just that you're willing to support this work and me means a lot to me. I'm super excited for you to be the first ones to see these results. This has been a labor of love for the past 10 months for me. So let's get to it. As many of you know, the Wisconsin Epidemiologic Study of Diabetic Retinopathy was initiated in 1979, and it's the sentinel study to assess diabetic retinal disease rates. It's still cited as a primary source for prevalence data even 45 years later. Historically, the US has preferred to use population-based studies to determine prevalence rates. Often these were most formed in specific minority groups in regional areas across the country. Examples of this are the Salisbury Eye, Lales, Project Ver, and MESA. There have been national population-based studies, usually through NHANES, but even the most recent data for them is over 15 years old now. There have been other population-based studies, which have been alluded to already today in SEARCH, but those have focused on just diabetic retinal disease and use and not really looking at the entire group of patients experiencing diabetic retinal disease. So why is this important? Well, over the last 20 years, there have been 4 new classes of anti-diabetic medications, more physiologic insulin analogs, and better ways to monitor glucose levels. Part of this, from 1999 through 2010, we saw that significant gains in glycemic control were made up till 2010. However, after that, glycemic control has worsened every year up through 2021. Also impacting this are macro level things like the Affordable Care Act. It has dramatically reduced the number of uninsured people in the US, and specific to diabetes, there's even studies that show that patients who were previously uninsured, who come onto ACA insurance plans, have improved their hemoglobin A1C levels for up to 2 years after starting. And then despite this, the incidence of diabetes continues to rise across the US. And how have all of these different factors, which some of them conflict with each other, have impacted the rates of diabetic retinopathy, diabetic retinal disease? So an important paper was recently released. It was a study that used mixed older population-based studies and more recent claims data to show that the prevalence rate among patients with diabetes for diabetic retinal disease to be 26.4% and vision-threatening diabetic retinopathy to be 5.1%. While this single point is really important for us to know, it doesn't tell us about which direction we're going or how fast we're going there with the prevalence rate. Nor does it look at the other important aspect, which is incidence. Are we creating more cases, or excuse me, are new cases occurring more or less frequently than before? So the objective of our study is to determine the trends over the past 20 years in the prevalence and incidence rates of diabetic retinal disease, which we defined as any form of diabetic retinal disease, whether it's non-proliferative, proliferative, or macular edema. Specifically diabetic macular edema, proliferative diabetic retinopathy, or combined outcome of the two, vision-threatening diabetic retinopathy. And I realize this group is working to change these definitions, but for now, this is what we have. We're going to do a retrospective cohort study. We're using Optum's de-identified Clinformatics Datamart database. It's an administrative medical claims data from all patients enrolled in commercial and Medicare Advantage insurance plans. It has over 90 million covered lives and includes all outpatient billing claims from 2000 through 2022. It also includes extensive sociodemographic information on people. We have 2 different cohorts that we're looking at. First is the prevalence cohort. This was defined as anyone with diabetes mellitus having at least one ICD-9 or ICD-10 code for diabetes, and everyone that had to have at least 1 full calendar year of data in the data set for inclusion. The incidence cohort was very similar to the prevalence cohort. However, they could not have any history of diabetic retinal disease outcome of interest, depending on which group we're talking about, and they had to have at least 2 years of data without one of those diagnoses to be included in the analysis. So our primary outcomes are the yearly prevalence and incidence rates of diabetic retinal disease. The secondary outcomes were the prevalence and incidence of VTDR, DME, and PDR. We use multivariable logistic regression to determine trends. Those diagnosed with diabetic retinal disease were considered prevalent for each following year that the patient remained in the data set. However, incident cases were then removed from future incident calculations. So I have to warn you first, I am going to be the bearer of bad news here. So 1, don't kill the messenger. But 2, there is some good news, and so hopefully as we get through the bad news, it'll be a little better here. This slide is not that important for you to specifically remember the numbers, but mostly I'm showing it so you can see how big the data set is that we're working with. We have over 6.1 million patients with diabetes. Of those, over 1 million had diagnosed with diabetic retinal disease, 417,000 VTDR, 286,000 DMEs, 225,000 PDRs. And of those, 477,000 of the DRDs were new or incident. 172,000 of the VTDRs were new, and 134,000 DME, and 87 of the PDR. So this is a little bit of a busy slide. So first, I want to point you to the yellow line here. This is the prevalence over the course of the 20 years. You can see that in 2001, we start off around 13.5% prevalence rate. Then through 2007, it decreases, at which point there's an abrupt turn and it starts increasing. So much so that it doubles all the way through 2021, or nearly doubles to 1.9. Incidence is the other line on the graph, and that's shown here. You see that initially between 2001, there was a 50% reduction all the way through 2014, at which point it turns around again and starts increasing. And unfortunately, it increases up through 2016 where it does level off, but it doubles once again from its low of 2014 all the way through 2022. We also did an analysis of a population, quote unquote, population level prevalence rate for everyone in the database. And in 2001, the overall prevalence was 0.6% for patients with diabetic retinal disease. And unfortunately, that increased 680% between 2001 to 2021, where 1 in 25 patients in the data set had diabetic retinal disease. Here, specific for vision-threatening disease, DME, and PDR, you can see that again, there was a big increase from 2007 through 2016. 40% for VTDR, 65% for DME, and 25% for PDR. Fortunately, this is where the bad news ends, and we start getting into some good news. First, after 2015, we saw a 10% reduction in each of the metrics that we measured here. When you get to incidence, the news gets even better. Each one of these had a tremendous decrease over time, and over the 20 years, there was a 60% reduction in the incidence of vision-threatening diabetic retinopathy, a 45% reduction in diabetic macular edema, and a 69% reduction in PDR. So just to recap and give some ideas, DRD prevalence through 2007 and incidence through 2014 initially decreased, but then the rate of each doubled through 2022. Why is this? Well, there is a much larger increased pool of patients with diabetes, as we already said. Diabetes incidence is increasing across the nation and has gotten especially bad over the past 5 or 10 years. I do think it's interesting that the rate of prevalence among diabetics only doubled versus the 6.8 increase that happened in the broader population, which really shows that it's just the amount of people that are fueling this that are becoming diabetic. Also specific to this time point, there's increasing rates of insured. We already talked about the Affordable Care Act. Nearly 45 million people today are now insured, and largely a lot of them probably ended up in this database because of it. There's also been a big increase in the emphasis on diabetic retinal disease screening exams, which may be allowing the detection rate of the diabetic retinal disease to be found sooner. The prevalence rates of VTDR, DME, and PDR increased from 25 to 60% from 2007 to 2015. However, each have since decreased 10%. The incidence rates over that time have dropped dramatically for each of those, ranging from 45 to 69. So this is a little bit of a nuanced story, and you have to ask yourself, are you an optimist or are you a pessimist? The pessimistic take would say that the prevalence rate of DRD is increasing so quickly that eventually a wave of VTDR is coming, and we just haven't caught it yet. Also possible is that screening is causing a latency bias where VTDR happens later in the disease just because it's diabetic retinal disease is being detected earlier than we would have done it otherwise. Personally, I take the optimistic take. I believe that we are truly doing a better job of preventing vision-threatening diabetic retinopathy and specifically PDR. I think the timing is interesting with the drop in vision-threatening disease, which corresponds to the broadening use of GLP-1R agonists. We can talk more about that later if you're interested. Also, the reduction in PDR corresponds to the broadening use of anti-VEGF, which we know can help prevent progression in that disease. Thank you.
Let me just ask Tianen to come back to join the panel, and then our panelists, Kerry Getz, who's the Associate Director of the NEI's Office of Data Science and Health Informatics, Tunda Peto, who's a professor of ophthalmology at Queen's Hospital in Belfast and runs the diabetic eye screening program for Northern Ireland, and Chris Sherman, who, in addition to being a PhD molecular neuroscientist, is the chair of our MTM Vision's lay advisory and was diagnosed, I think, at age 6 with type 1 diabetes. So I don't have my notes, which is good. So maybe I'll do this extemporaneously. The topic of this session is use of AI and real-world data in assisting us in doing a better job of diagnosing, predicting risk of progression and applying new therapeutics, to individuals with diabetes and diabetic retinal disease, but also using it as, thank you, using it as a means through which we can better qualify patients, for clinical trials and so forth. So the question is, first to Brian, my big concern with real world data is it's dirty. And it really doesn't, it's very hard to discern, and Tunda, you can comment on this as well. So how do we look at real world data as a contributor to clinical research data to this kind of new staging system, severity scale, and means through which we make clinical decisions and research decisions?
So there's a couple answers to that. The first being, we are using real world data. So depending on whether it's messy or not, the reality is that the number of people being diagnosed with diabetic retinal disease is exactly what I presented, because that's what they're being diagnosed with. The flip side of that is when you have real world data, the real key is the size. So there are going to be errors in it, but if you get enough data and you accrue large enough sample size, the errors are going to cancel each other out. And that's the benefit of the real world data, assuming you get enough size. And with that, I think it becomes very usable to use that data, and that's an important aspect that often gets overlooked.
Cindy?
So we have a lot of national data in the UK thanks to our electronic care system. And when we use that data, a lot of the times we learn about the population, we learn about what we actually do, we learn to ask new questions. So just to give you an example, when we looked at 4 major centers for diabetic eye treatment, the main issue was that how we're going to harmonize the scores, because you can, although it's the same electronic care system, there are ways of inputting severity of the disease. But also what happened was that we get all the patients from diabetic eye screening referred, and then we had their 5-10-year follow-up. And we suddenly realized that about 50% of our patients in 5 years did not need treatment for diabetic macular edema they were referred for. And they did not lose sight. So we have a huge amount of people under our care who actually requires something that keeps them in that stage. So we really need to work with the drug companies, and we need to work with the diabetologists to elongate this period when they can stay in that untreated, monitored, good vision state. But we never realized the amount of people coming in and staying in that category. Also, you learn about how you treat. You learn about how much variation is between centers, even if you work towards the same guidelines. So I think you can also use real-world data in asking the correct question, and ask questions that you otherwise wouldn't have been able to ask.
So in that, was there anything that you were able to discern that separated those two halves of, kind of an indicator in the data that suggests that this group are the progressors and this group are not?
Not quite there yet. We are looking at the images. It's tens and thousands of patients, so we're working on it. But it was something that we never expected to see. And if you look at the graphs, they're all just completely stable, good vision for 5 years minimum.
Yeah. So one of the premises of our work is that the current system of diagnosis and staging is inadequate, and especially does not give us insights into early stage disease. So I'm going to ask Carrie, how do we, in going forward, doing the clinical studies that we're doing, encouraging the community to test out functional variables and other promising variables that can be put into this basket that can then be used to predict risk and identify patients better for therapy? How do we marry clinical studies with real world data so that at the end of the day we have something useful for the clinician, at a point of care?
So I have several thoughts on this, but mostly it's about interoperability. Like we said, the ICD codes, they are what they are. It's another point of data. And I would say biomedical studies, clinical trials are not necessarily cleaner. It's just another source of information. I really try to encourage people to align your standards and any data you're collecting making sure that's interoperable and consistently curated and maps to standard vocabularies and ontologies whenever possible. The messy part of observational data, at least from what I've seen, is the actual elements related to visual acuity and the things that the doctors are recording in the exams, but not necessarily the diagnosis codes. So I just try to encourage people to align that, share your exact standard representations so that those can potentially be aligned with the work that we're doing with the AAO Standards Working Group and the Odyssey Working Group to identify gaps in terminologies. And then I also want to point out a lot of the things we're talking about with imaging, especially, imaging is not necessarily connected to an electronic health record. Right? And so when you're talking about that, you have to notice that as well. If you're looking for labels on an image that correspond to an ICD code, you would not necessarily find that in our current healthcare system. So we all need to kind of be aware that that interoperability doesn't exist, at least in the United States, and advocate for more of that interoperability.
Yeah, thanks. And Tian'an, in DR Predict, you weren't using any functional data. Is there an opportunity to now lay over some additional data sets onto the work that you've already done?
I mean, that's really retrospective data.
Yeah.
And I mean, you're quite right, there's no functional data there. Even visual acuity, there's some data there, but that wasn't really used in the analysis. I think it's always very difficult to go back and do things retrospective. But I think moving forward, I think prospective data collection is going to be really important. So things like what Dr. Kuteria is doing in every read, I mean, I think that's a real source of very important data. And if you can decide things prospectively, then you've got a lot more opportunity to look at things.
Of course.
And I would suggest probably, being broad at the beginning will probably pay off in the long run, I think. But when it's retrospective, that's
Yeah,
really
and
difficult.
so those of you who are not familiar with AR and AS and the protocols and the additional functional variables that we're looking at in those trials, we would really strongly encourage you to learn, and because we would like others in the community to start to look at those same functional variables in their studies, so we get a much bigger N and we can figure out if these are really useful new variables to be included in care and in research.
Can I just come to one point on the variables? So those of you who work in grading centers as well, you know that sometimes we'll grade up to 100 so a normal diabetic retinopathy grading minimum generates 179 fields if you do 7-field stereo. A lot of the times, even in clinical trials, we only use a few of those variables. So we actually have a huge amount of data out there, even on clinical trials, that we probably haven't really looked at in big details. So that's the same kind of a problem that we have, that a lot of the times we throw away some of that stuff and it just sits somewhere. So my plea a lot of the times is that if you can do secondary data and image analysis, if you can do, and then you can marry it up with the real world data, we can try to come to some sort of a term as to what was useful in clinical trials to grade for, because we'll never be able to grade for that much unless AI gets so good. In clinical setting, you can't have 40, 50, 60 people in your office and grade 179 variables.
Yeah.
But if we can learn from those, we can change the way, potentially, how we look at some of the real world grading.
Go ahead, Karen.
And I just want to tag on to that. So our office does a lot with data sharing and data management. And I'm often struck by how siloed people are with their data, and the ability to share well-documented, semantically, syntactically representative data broadly, because I'll say right now, the way ophthalmology has really isolated things leaves out the students who are the ones going to be developing the really cool applications here.
Yeah.
So the more open we can be, the better off we'll be as a community in the long run.
Yeah, and Chris, from the standpoint of perspective of someone with type 1, but also the notion of using real world data, well, it's your real world data that is being used. So are there objections? How can they best be utilized? What would you want to be able to contribute?
I obviously don't speak for all patients, but yeah. For myself, I'm happy to contribute data, and I'm happy to be involved and engaged in clinical studies and other sort of pushes to obtain more relevant clinical data from patients and patients with different stages and or not the disease. I don't yet have retinal disease or the onset of retinal
As we
disease.
currently define it, right?
Yeah, as we currently define it, and I'm hoping to keep it that way. So, I really care about early detection and early intervention.
Yeah. Jinan, you had something else?
No, I just wanted to say on Tunde's point previously, I mean, I think, all that additional data and variables that are available, and it's kind of what Kerry said, is that it's really important, I think, to release the data or for the data to be available. And sometimes it's just, a second pair of eyes or a fresh pair of eyes, because when you're conducting a study, you have a particular hypothesis in mind, but you're actually collecting a lot more data with somebody else who looks at the data with a fresh pair of eyes could really figure out additional interesting hypotheses and analyses that I think are very useful. So yeah, I totally agree.
Yeah. Do we have questions from the audience? Or, yeah, Jenny?
We do have a question from the chat from Monica, and I think this came up during Tinan's presentation on AI. And her question was, can you also add other clinical data like continuous glucose monitoring traces or ambulatory glucose profiles to help predict specific outcomes in diabetes?
Yeah, I mean, I think if that data is available and if it's married to a data set where you've got outcomes and you've got longitudinal data, then there's every reason why you should be able to do that. I've not had, I don't think we have any access to a particular data set that has that, but I think that's definitely something to look at, and that's kind of complex data or difficult to interpret data that would be a very good use case for this, in my opinion. I think, yeah, a very good point.
Others? Please.
Yeah. Thanks. So Dan, I have two questions. One small question on looking at OCT changes when you're looking at therapeutic response. Do you think AI could get to the point of knowing when there is a decrease in thickness versus atrophy and looking at those long-term neurotrophic signs that we might be seeing? And two, maybe for the whole panel, what are the steps that need to be in place to use these technologies for AI and imaging in large-scale trials?
Yeah, thanks for the question. I mean, I think that hits on an important point in that when we measure retinal thickness, it's actually a proxy, in this case, for fluid, right? Because we're looking at the fluid as a marker of activity, leakage from the diabetic macular edema. That's what we're really interested in. But we use retinal thickness as a proxy because that's easily measurable, and fluid quantification is not easy or is tedious. So I think if we can move towards, and there are groups that have done a lot of automated segmentation with AI on fluid. And I think that if that becomes more readily available and we use that, you're more likely to get the answer that you want, because overall retinal thickening is not actually measuring the disease process that we want. And that may help to sort of separate the atrophy aspect from fluid. I think other biomarkers have always been challenging. I mean, we know things like ellipsoid zone loss and drill and all that are associated with visual function, or at least with best corrected visual acuity. But automated segmentation of that and identification of that in a large way has always been difficult. And I think that would really allow more useful analyses. But it's very tedious to manually grade these things. We can see them qualitatively when we see a scan for a patient in clinic. But if you want to have a larger data set to analyze that, then you need tools available. That's my take on it.
Tunde.
So if I can get to your second question. So I think AI in isolation is actually probably a wrong concept, sorry to say that. So what you need to think about is the health system you're embedding into, how the patients get to the hospital. Do we really need to think about who will see the patients? So in the UK, the equation will be totally different because we have technicians doing 90% of the work. We don't see those patients who we don't have to see. So for us, the pay and the reimbursement will be very different. So we need to think about AI as how we're going to do it right from the very beginning of finding the patients, getting them to clinic, making sure that they get their results on time. The analysis of the images is one step. If we don't carry through in the health system that we're using it in, it will not have its full impact. It will help with getting patients through quickly and will help to get the images analyzed, but it probably won't have the impact that it should have if we don't get the whole of the health system right.
Well, so that asks the question. So back in the day, early development of EMRs, there used to be a kind of an automated reminder system whereby if your patient had recorded that they were smoking, in every visit you'd ask them, are you still smoking, right? So the question is then, can we kind of use that same sort of an approach and deploy an AI algorithm that is ongoing, analyzing the EMR and all the different interactions with the healthcare system that an individual has and all the data that's being collected on them to provide reminders or prompts to the clinician that this is the status according to our new staging construct, and this is the therapeutic, direction that should be explored. Go ahead, Brian.
I would actually argue you got to take it one step even before that, because such a big portion of vision loss in diabetes has to do with patients who just don't follow up. So you need to get the patient in the door before you can even
so the
address
reminder
all
has to
those
be the
AI.
patient first. Yeah, for sure.
And so figuring out who's at risk for not coming back and figuring out how to get those people back in the door is going to be a huge win to try and keep vision loss from happening.
So I got a question.
Other
for
questions?
Brian.
I'm sorry. I can't see because lights are in my eyes.
Oh,
Yeah, I got a question for Brian.
Carol Chen from the Chinese University of Hong Kong. So I just want to share some of my thoughts on our recent AI work. First, what we are trying to do is translation and more focus on how to benefit to patients and how to benefit the healthcare system. So I know that there's some commercial DR algorithms already, but we still have lots of discussion. What is, how can we, what is the cost effectiveness? What is the standard? What are the proper guidelines that we can adopt in healthcare system, particularly what I mentioned in Hong Kong. So I want to say that there's no clear guideline for AI in ophthalmology, that how we can use to translate that in real world clinic. So that's a comment I would like to give and look forward to panelists and other people's comments. And then second, I would like to talk about is about how, because there's new AI techniques are coming. So for example, there's interpretable AI techniques because the AI that we developed before, I don't know what Tian'an they're doing, is still black box. And then the acceptance of these AI models are actually are not accepted by clinicians and also by patients as well. So I think we need more new technologies to make sure that people are more acceptance for these techniques, particularly when I think right now the AI algorithms are frozen, and with this new with more and more advanced technology, how can we upgrade the AI system? So again, there's no clear guidelines or standards when there's new AI algorithm, for example, DME detection or DR detection. So we should focus on using the new technologies to enhance the performance. But there again, there's no clear guideline for this. So I would like to just open this, what I'm facing, particularly the deployment, translation, and upgrade of the AI algorithms to the panelists.
Thank you. So I'm going to just take moderator's privilege and invite Dr. Abramoff, I'm going to surprise, to comment about AI guidelines in ophthalmology. And what we're looking at next is the questioner commented that it's very difficult now to start to apply AI without that guidance.
I think thanks for the surprise opportunity. I think the ADA guidelines for American Diabetes Association to say that autonomous AI use is appropriate for patients with diabetes, to screen for diabetic retinopathy is a big thing. That's a part of the standard. More in general, I think literally today a paper came out in JAMA Ophthalmology showing that AI is only reaching like 0.1% of all patients who need it, meaning all the people with diabetes that we just saw by Van der Beek's study. So there's a lot to do. And I don't think, having been involved in almost 1,000 sites implementation of luminetic score, what it used to be IDX-DR, we worked really hard on reimbursement. We worked really hard on getting it into guidelines. We worked really hard on liability, all of that has been essentially solved. And still, utilization is slow. It's increasing more rapidly than a few years ago. That was thanks to national reimbursement. So that's a big deal that you can now, on average, get about $80 per patient, and a little bit more in value-based care, which most of you are not familiar with, but most of the healthcare dollars actually go to value-based care. So let's not go there. But yeah, utilization is slow because there's just a lot of inertia. And so that may also be a warning to all of us that as we develop new technology and innovation, getting this to actual patients and actually improving patient outcome is not easy, and we need to think about it very early on.
Thanks, Michael. Do others on the panel want to answer the question?
I just want to add to that. So where I'm seeing a lot of momentum is the use of OCT for referring from primary care and in a broad scope, especially rural, underprivileged, low-resource environments. That's where you're getting a lot more adoption. But again, it comes down to reimbursement. What is encouraging a primary care doctor to do an OCT, right? And it's to be able to say, like, you have diabetes, I'm going to screen you and give you a referral and triage, right? So that's one avenue. But another potential thing is the use of OCT in oculomics. So we've shown with lots of studies that there are links from color fundus photos and OCT to other conditions such as heart disease, cardiac. So like we need to think, in my opinion, again, is that we need to think bigger than ophthalmology and just eye care. How do we use our advanced imaging technology in other areas so that we can start pulling more ocular information into the whole health system, not your eye doctor down the street who's keeping the images on his device until the hard drive gets full and then deletes them. Yeah. So that's my advocacy for this community is we need to do more, think more broadly, think bigger.
So I'm being given a time, but Marianne, did you? I see you waving at. Okay.
I can go next. Dr. Vanderbeek, just a follow on to the GLP-1 agonist. I left on break saying, I wonder what's happening with the SGLT2s and the GLP-1s and sort of the impact, again, beyond just ophthalmic situations, but others. What else can you elaborate there? And have we gone to the drug companies? I know Big Boehringer's here to ask what scans they did in their studies to look at the controls versus the active. Some of those are 5+ year studies. So maybe we could look at the impact on DRD as well. And then my only other question, we talk about the correlation with obviously disease control and HbA1c. Has anyone ever looked at the amount of insulin people take to get control as a contributing factor to complications? Because we know a lot of insulin as a growth factor can have its own issues. Have we looked at any of those correlations?
So I'll answer the second one first because it's easier. I have not looked at that, and I'm not aware of anyone who has looked at the amount of insulin. It is an interesting avenue and definitely should be looked at. The harder question is the GLP-1R agonists. So it's a little bit of a nuanced story in of itself. When you look at the clinical trials, SUSTAIN-2, and I believe it's called the LEADER-1 for semaglutide and liraglutide, they actually showed increased risk of progression of diabetic retinopathy or diabetic retinal disease. When you boil down to what's going on there, one, it's very small numbers. And so the trial wasn't geared to look towards an eye outcome. It's a safety signal they happen to find where you're looking at 12 versus 5 in the placebo group. So it's not rock hard evidence one way or the other. The broader picture, and because there have been observational studies to look at it, the broader picture or thought, especially to GLP-1, is that the clinical trials actually compared GLP-1 agonists to placebo. And in reality, that's usually not what the endocrinologist is deciding. What they're deciding is we're putting them on a new medicine, which one do we put them on? And when you make that comparison, you don't actually get that signal of worsening. And then my hope, and I have less data for this, is that you look at the GLP-1 receptor agonists and pretty much every complication of diabetes is reduced on them. It would be weird for diabetic retinal disease to not be one of them. And I think one of the things that happen when you get an active comparator to placebo is you're getting paradoxical worsening. And so once you get past that paradoxical worsening, which is usually transient in and of itself, I think the long range term is where you get the good outcomes.
Marianne, did you have a question?
Yeah, can you hear me? So I actually wanted to make a comment about how we've been talking a lot about clinical trials and endpoints and imaging and all that. But I want to go back to what Tunda said about the importance of really analyzing all the data that we have sitting and really looking at our real world evidence. Because if we're thinking about changing clinical practice, in much of the world, there are a lot of people, as Tunda mentioned, that are waiting. They're in a holding pattern waiting to get worse. And we can only make the case for treating them early if we can quantify the number of people waiting and demonstrate what that means. So it's really important to also, allocate much of our resources and our brain power to trying to understand those patterns. And, I want to commend Aude and you and others who are leading this type of work to really understand what is going on to patients who are not being treated.
Yeah, thank you. Oh, hey, Adriana.
I don't actually have a question. It's more of a comment. Well, maybe it's a question. If we're using AI, isn't it important to try to get pictures of patients as early as possible? And we should make it so that when a person is diagnosed, when they're learning how to take their insulin, get shots, they should be taken for photography of their eyes so that we have a baseline so that we are able to catch disease before, it gets harder and harder, disease progresses.
Yeah, I think that speaks to what the guidelines currently are for recommendations of referral for, comprehensive ophthalmologic exam in a person with diabetes. And I certainly would be supportive of doing it on diagnosis, just for the reason Adriana suggests, is to have the baseline assessment, because we actually don't know what's happening in those first 5 years or 8 years. And we're certainly not doing the functional assessment that might give us earlier signal as to, who might stick in the 50% that waits and who might be in the 50% that progresses. But go ahead.
But we need access to those images as researchers. I'm a data scientist and I can't get access to them. Students who are advancing models can't get access to them. So that's really where the holdup is. They exist. It's just the access is really challenging.
Thank you. Thank you, panel. Thank you all for a highly engaging conversation.